Good evening. I'll be speaking on pearls and pitfalls in interpretation of OCT in diagnosis of glaucoma. There are four different manufacturers of spectral domain OCT, and we examine three different parameters for diagnosis of glaucoma. We have to remember each machine has different scan patterns and different software, so we cannot compare the data of one machine with another. First of all, we must check the patient's name and age, because all data is compared with age matched normative database and color coded accordingly. Then we must check the signal strength, because there is a minimum acceptable quality level for each machine. For example, Cirrus, it should be more than 6. For Topcon, it is more than 45. Lower signal strengths give lower RNFL thickness. So a drop of lubricant not only improves the signal strength but also RNFL thickness. It has been reported that there is a 9% increase in average RNFL thickness after cataract surgery also. Next, we must know the color codes. This is important because the values more than 95% are labeled as white, and the values that are not compared with the normative database are shaded grey. So not only red and green, we should also know white and grey besides red and green. In our over enthusiasm for embracing OCT in the diagnosis of glaucoma these days, we have come to a point that sometimes we rely solely on the colors for the diagnosis, and this should not be the case, and this has led to the terms called red disease and green disease. Every technology has its own limitations. Sometimes the blood vessels cause shadowing on segmentation, giving lower RNFL values. Sometimes we used to see in the past motion artifacts characterized by horizontal displacement of images, but nowadays this is not common because of faster acquisition of images. Sometimes a floater comes in the path of calculation circle, giving us lower RNFL values, and this changes to normal after blinking when the floater moves away from the calculation circle. So broadly, all the artifacts in imaging can be divided into three groups: the patient dependent, like media opacities or dry eye; operator dependent, like signal strength or scan alignment; or device dependent, like normative database. So this Heidelberg printout shows red colors on sector analysis, and when we see the fundus, we see the toxoplasmosis is the cause of RNFL thinning. So this is not glaucoma. This is a Cirrus printout showing lot of red areas in sector and clock hour analysis and RNFL thinning on RNFL deviation map. But when we check the fundus, we see that these are myopia. And in myopia, the superiotemporal and the inferotemporal bundles converge temporally. So the height or the RNFL thickness is normal, but it is displaced laterally. So in the expected areas, they appear to be thinned out. So this is myopia and this is not glaucoma. This is Cirrus printout showing red areas in the RNFL table. So when we see carefully, the disc has not been centered properly. So when we center the disc, all the colors change to green. So this is a centration error by the operator. Another printout from Heidelberg showing red areas in the sector analysis and RNFL thickness in the TSNIT graph dipping into the red zone. But if we observe carefully, we see that the RNFL tomogram has not been centered properly. And once this is centered, the values change to green. So this is again a centration error. I'll be giving a couple of examples because of the constraints of time. So this next example is from Heidelberg showing a lot of red areas and the RNFL thickness dipping to 0, which is not practically possible because of the presence of glial tissue and blood vessels. And this occurs usually in tilted disc and posterior staphyloma in myopia. So this is a device dependent segmentation error. There's another device dependent error, and that is normative database. Each machine has its limited normative database. For example, Cirrus has a normative database of 284 individuals only in the age group 18 to 84 years, and refractive error -12 to +8 diopters. So due to this small normative database, many results may be flagged abnormal statistically, because these patients are not represented in the database. but they do not represent the real disease. So we should be alert about these facts and not overtreat this red disease. The vice versa is also true. Sometimes there may be a patient of glaucoma, but that may be masked by the green color. So this patient has glaucoma in both the eyes, but the OCT has picked up glaucoma only in the left eye. And when we see the fundus, we see that there is a myelinated nerve fiber which has caused the masking of the RNFL thinning. And in fact, this is in white, more than 95% of the thickness in the OCT. So we should be careful about the other end of the spectrum also. Another important point to remember in OCT is that the RNFL thickness cannot go below 40 to 50 microns because of the presence of glial tissue and blood vessels. So in advanced disease of glaucoma, we must rely on automated perimetry and not on OCT. To summarize, OCT alone should not be used to make the diagnosis. An abnormality in the OCT requires clinical correlation, and this is not man versus machine, but man plus machine. Thank you AI Scientific Committee, especially Dr. Partha Vishwas and Dr. Amit for giving me this opportunity, and Happy New Year to all.